Welcome, everybody. I'm Janelle Rios. I have a faculty appointment at the University of Texas Health Science Center at Houston, also called UTHealth, and I happen to have my appointment at the School of Public Health. And we are located in stormy Houston, Texas at the moment, which is part of the reason we're having some technical difficulties. And I'm actually coming to you from the Texas Medical Center, which is the largest medical center in the world. And we are so pleased to have all of you with us. Today's webcast is going to be about prevention and preparedness. And this is a webinar series that we do. Today's topic of conversation is going to be Ebola virus disease. It's really timely, so we put this panel together. And before we get started, I do want to thank the Texas Department of State Health Services for a wonderful session on Ebola virus disease that they presented last week. I hope many of you were on that call. Clearly, the state and local health departments are working hard to maintain the public's health, as well as the federal government. They're working just as hard, and we definitely appreciate all of these folks. We're happy now for the opportunity to continue the conversation. So what we'll be talking about today, as you can see on the screen, these objectives are to explain the epidemiological, clinical, and public health factors of the current Ebola outbreak, which is very different from past outbreaks. Evaluate the field level challenges encountered during Ebola outbreak response efforts, and those challenges are significant and vary depending on which country you're in. Examine the strategic role of the Galveston National Lab in supporting infectious disease surveillance, diagnostics, and outbreak response activities. Here in Southeast Texas, we are so lucky to have the Galveston National Lab and the resources that they provide. Assess the potential risks associated with Ebola transmission in the United States, and respond to common questions and misconceptions regarding Ebola disease and outbreak management. So we're very excited to present all of this to you. First, a little housekeeping. So I'm not quite as familiar with Zoom as I am with Teams, so I am told that if you need closed captioning or just want closed captioning, click the more, which is 3 little dots, and then in the drop-down menu, it'll say show captions. And that's very convenient. I use it all the time. Please use the Zoom Q&A to ask questions. We have a wonderful graduate research assistant, Chi, who is taking a look at those, and then she will present those to me, and I'll be asking those questions of our moderators. In addition, upon registration, you had the opportunity to ask questions. So we have printed out those questions, and I'll be asking as many of those as I can. We had a lot of questions that came in. So chances are we won't get to yours, but we've grouped them together. Hopefully we'll get some answers that make sense and are practical for you. At the very end of this activity, there's going to be a slide with a QR code. Please take that survey. It really helps us understand how well we did in presenting this information to you. And please be very open, honest, frank in your responses. And we are recording this webcast. So in about 10 business days, maybe sooner because Dana is amazing, you'll be receiving an email with a link to the recording. So let's move on. This webcast is brought to you by the Prevention, Preparedness, and Response Consortium, or P2R Consortium for short. The P2R Consortium has been around for 16 years. Actually, this month we started our 17th year. I'm really proud of that. I happen to be the PI of that big consortium. Our partners are the University of Utah and Texas A&M University, and we offer training, health and safety training in using an all hazards approach. So not only infectious diseases, but emergency preparedness and response related to hazardous materials, radiation safety, biological safety, CPR, Stop the Bleed, and a ton of things. We are funded through the National Institute of Environmental Health Sciences, and that is our grant number down there. Where I am happy to have any questions come to me about the P2R Consortium. Now, with that, I am so pleased and honored to present our first panelist, who's going to introduce herself. So, Beth Ann, would you like to introduce yourself at this time, please?
Sorry, sure. Thank you so much, Janelle. I appreciate that. Hi, everyone. My name is Beth Ann Moscow. I am at UTMB with the Division of Global Partnerships at the School of Population Health. I also work with Janelle at the P2R Consortium. And I'm going to before coming into academia, I spent many years working for USAID, and part of my job during that time was to work on the Ebola response in 2014, 2016. So I'm going to be talking to you a bit about the perspective of that outbreak and sort of how it compares to our current outbreak. So that's a little bit about who I am. So I did have, as I mentioned, the privilege of working on the 2014, 2016 West Africa outbreak, and at its worst, it was threatening to spiral into a global sort of catastrophe. But ultimately, we were able to bring it under control with a huge and kind of extraordinary convergence between funding and global coordination. Critically, also this deep sort of community partnership. So I'm going to draw upon that experience today and, share with you a little bit about what we did and then compare it to what's happening right now in the DRC, and sort of look at, where the differences are and make some maybe recommendations about things that we need to be thinking about. So the first thing we need to look at is the virus itself. And when we look at the 2014, the 2016 virus, that epidemic was actually caused by the Ebola, the Zaire Ebola virus. Okay, and this strain has about a 90% case. It can go up to a 90% case fatality rate. So it's actually has a slightly higher case fatality rate than the current virus that we're experiencing. But by 2015, 2016, we did have a vaccine. The Eribol was available under compassionate use. We also had various therapeutic interventions that were available during that time. So that helped to contribute in terms of our ability to respond to it. This current outbreak, this involves the Bundibugyo strain, which was identified in Uganda in 2007. This has got a case fatality rate of about 50%. So the case fatality rate is a little bit lower, but there is no approved vaccine. There's no specific therapeutic interventions for this strain. So frontline responders are operating without those pharmaceutical tools, which were so critical and sort of game changing in the 2014, 2016 outbreak. So that's the first difference we can think about. Just sort of contextually, as of June 16th, 2026, the DRC has reported 808 confirmed cases and 192 confirmed deaths, and with I think 26 new cases and 11 new deaths, which in the last 24 hours alone. Uganda has about 19 recorded cases, so it's moving, and things are happening rather quick. So when we look at it from that perspective, the science is pretty clear. No approved vaccine, no approved treatment. It's not really an inconvenience. It kind of fundamentally changes the calculus of response. And it places the entire burden of control on behavioral, epidemiological, and community-based interventions. And those are the very interventions that require trust, local engagement, and sustained funding infrastructure, which has shifted. And so that's impacting our ability to respond during this current outbreak. So when we think about what actually worked, in addition to the science behind it, what actually worked in West Africa, I'm going to talk about sort of 5 key interventions and how they worked in terms of responding to that outbreak. So the first thing was safe burial teams. Now, when we look at unsafe burial during that outbreak, about 60 to 70% of transmission was linked to unsafe burial. And this means that there was certain practices that were taking place in the region around burial, which were linked to religion, linked to culture, in terms of handling the deceased individual, in terms of interaction with their body, and so this created a high rate of transmission and created a lot of challenges. Once we recognized that as a problem, we were able to step in and put in place safe burial teams. Now, safe burial teams is not just a quick activity. Let's just put it in place. This required a lot of effort, working with communities, working with local leaders, understanding the culture, identifying volunteers, looking at really what was the best sort of approach in terms of getting those safe burial teams up and running. So again, it required a large community movement to get those teams in place. We funded, USAID funded about 190 safe burial teams in across the three countries, and it really turned the tide in terms of the outbreak itself. Secondly, is community engagement. We worked with various different, or USAID, CDC, WHO, other partners, worked with various organizations and local community groups, community leaders. I think in Liberia alone, we engaged with 15,000 community leaders. We deployed teams. This really helped to get the community involved. This is not something that experts can just come out and handle. The community members have to be involved, because to break that chain of transmission, you've got to have behavior change. You've got to look at best practices, how folks are interacting, and so that's where the community engagement is so critical in terms of changing the trajectory for the outbreak. So that was a key component in that outbreak. Thirdly is the healthcare worker, or the health worker training. Okay. There was teams of folks deployed, both from CDC and from USAID, as well as other donors involved. And we were able to train about 25,000 healthcare workers. Okay, so again, these are folks who are on the ground working in communities, who can be part of that response, who can be help to identify, where potential cases may be, who can help with interventions. They also became the backbone of surveillance and case finding, which is absolutely critical in terms of understanding where the disease is and where it may be going to. And so that was a critical piece. Fourth is surveillance and contact tracing. There was a large amount of support provided for technical support provided for epidemiology, looking at labs, building capacity for labs, case investigation. And this is really where you can allow those chains of transmission to be broken. And so the support across the board within surveillance and contact tracing, significant contribution. Finally, are the military logistics. The DO, especially the US DoD, France, and the UK, provided significant logistical support to help build ETUs, or Ebola treatment units. Without those units, you have no place for folks to go to. And so having that logistical support, a coordinated effort, the US built ETUs largely in Liberia, France was building them in Guinea, and the UK was building them in Sierra Leone. So with that logistical support, you had the facilities available to treat patients and cases. And so when I think about the essential lessons learned, from this from the West Africa Ebola outbreak that I was a part of, those technical interventions really only worked because of the relationships built on the ground. These communities and these groups oftentimes had organizations and NGOs in place already. Connections with community leaders were already there. So when you have to go into a community wearing a PPE, or personal protective equipment, a big yellow suit, and you're walking into a community, it's less intimidating if you can work with community leaders to help folks understand why we're there and what it is that we're doing. And so it wasn't just about presence, it wasn't just about funding and having, individuals show up. It really was about presence, trust, and institutional memory. So those components were very critical in terms of helping manage the outbreak and break those chains of transmission, like I said. When we shift now to the current outbreak that's happening in the DRC, the Secretary General of WHO had called this a catastrophic collision of disaster and conflict. And so there are a lot of additional challenges that are happening in addition to the science, the different type of virus that I already mentioned. Conflict alone does not explain the failure, but obviously it is a significant contributor to why the failure is happening. So the first thing we need to look at is the armed conflict and the humanitarian sort of access. With an armed conflict, opening up humanitarian corridors becomes challenging. The current outbreak is centered around the Ituri province in the DRC, which is also where the Ituri rainforest is, which is a very dense area. It also has a lot of natural resources that folks are very interested in, but it's a very volatile region. Okay, there's a lot of conflict going on. There's multiple armed groups that are converging within this region, and so it makes it very difficult. And you've got not just militia from DRC, but you've got Rwanda-backed M23 that's there. You've got a lot of different groups that are converging and creating a conflict zone, which makes any kind of intervention for anything very, very challenging. There was a report from the UN about a year ago that looked at these persistent attacks that were taking place from these malicious groups, not just on communities, but particularly on health facilities, killing civilians, killing workers who are there, sort of really creating a lot of widespread displacement, which again contributes to the challenges in terms of responding to this. There was another situation in the report where three Ebola patients had fled one clinic when it was raided by the Allied Democratic Forces, the ADF. They raided in northern Kivu, and then they moved and left, and no one sort of know where they went to, and so it made things like contact tracing nearly impossible. Um, One of the things that's important when we talk about contact tracing, to get to containment, with Ebola, you need about a 90% threshold. And this is sort of where the line is drawn in the sand. In DRC, currently, we're only about 45%, which is far below that 90%. So when you can't do that contact tracing, it makes it very difficult to understand where the cases are, where they've been, and where they're going to. And that, again, contributes to our inability to break the transmission. Um, Mistrust is another. So you've got the armed conflict challenge, the humanitarian access challenge with the conflict. You've also got a lot of community mistrust. One of the things that's happening a lot in the Ituri area, the province, a lot of the deaths and a lot of the issues are oftentimes attributed to things like poisoning, to witchcraft, to traditional cultural practices. And we actually saw some of that in the beginning of the outbreak in Guinea, where traditional healers were trying to heal communities from, some kind of bad juju that had been put on the community. And we had to, but because we had relationships with the community, we could work with community leaders and help to understand that there is actually something going on here. Another comment by WHO Director Tedros mentioned that community leaders, when he was visiting there, told him, nope, Ebola is not real. It's not a problem. It's not real. So when you've got this sort of mistrust that's already there in the system, is this actually a problem? Overcoming it becomes all the more challenging. So this is there's actually a program that's been supported by WHO called coexistence rather than confrontation, which is this sort of model working with traditional leaders, working with survivors to help sort of raise these issues and bring attention to what actually is going on, which is a great strategy. But they require funding, they require individuals, they require sort of a sustained presence to ensure that they have impact. So it makes it more difficult. Um, Additionally, one of the things that we've seen is a significant shift in global funding priorities for organizations in the U.S., in other countries. We're seeing a real shift of how investments are being made, and that's had a direct impact in terms of our ability to move these kinds of programs onto the ground. So when we saw a decline in funding and a shift in personnel, we saw programs that had been in place already, building some of that community trust, building those community interventions now have gone away. And so to get to a place where you can rebuild that community trust, it makes it very difficult when we don't have the personnel, when we don't have the staff. Africa CDC has lost a significant amount of their funding. We've seen a lot of places where we've seen a shift in those funding strategies and funding priorities, and so it's made it very difficult without that level of investment. And again, it's not just a huge plus up in terms of our resource, but it's the lack of the sustained funding in terms of programming that's happened. Personnel, we were during the West Africa Ebola outbreak, we were able to mobilize huge numbers of personnel to bring them into the field and helped with the response, and that is no longer there as well. So I know I'm running out of time, but I just wanted to make a couple of quick comments. We've got the strain difference, we've got the vaccine, we've got the lack of approved treatment, we've got the difficult geographical region, we've got the lack of funding, we've got the lack of personnel, all which have made it very difficult. I think my time is up, so I'm going to stop here, and we'll hopefully be able to answer any additional questions that you have. Thank you very much.
Thank you, Beth Ann. Beth Ann, would you like to introduce Dr. Haney?
Yeah, sorry. So I'm going to introduce Dr. Hani Sarag. He is the director of the Division of Global Partnerships, where I work, and an associate professor in the Department of Health, Population Health and Disparities at the School of Public and Population Health at UTMB, or University of Texas, Galveston. So I'm going to turn it over to Dr. Sarag, who will introduce our additional panelists. Thank you.
Thank you very much, Bethan. I'm honored to introduce two international leaders who work at the Galveston National Lab, starting with Dr. Scott Weaver. He's currently the director of the Institute for Human Infections and Immunity, and also he is the scientific director of the Galveston National Laboratory and the chair of the Department of Microbiology and Immunology, ranked first nationally among its peers for National Institutes of Health funding. Dr. Weaver also holds the John Seeley Distinguished University Chair in Human Infections and Immunology. He directs 3 major NIH and centers grants at UTMB, including the Western Gulf Center for Excellence for Vector-Borne Diseases, the West African Center for Emerging Infections Diseases, and the World Reference Center for Emerging Viruses and Arboviruses. Dr. Geisberg is a professor at the Department of Microbiology and Immunology at University of Texas Medical Branch. He has considerable experience conducting experiments utilizing non-human primates in high biocontainment, with 30 years experience in that. Also, he has sound experience at the U.S. Army Medical Research Institute, infectious diseases, and at the Galveston National Laboratory. He has experience in managing large research programs, including a current U19 Center for Excellence for Transnational Research grant. His research interest has focused on the study of hemorrhagic fever viruses, and he published extensively in this area. There are a lot to say about both of them, but I will stop here to give them time to present.
Wonderful. Dr. Weaver, your opening remarks.
Yeah, I'd like to begin with just to build a little bit on Beth Ann's comments, the historic perspective on Ebola viruses. I've been around almost since Ebola virus was first discovered in the 1970s, and the progression in the way that we view these viruses and their risk to public health has changed tremendously over that time. Initially, initially, these viruses caused small outbreaks. They tended to be in isolated parts of Africa, involving typically a few hundred people. They were not considered major international threats because they never spread very far geographically. Groups like the U.S. Centers for Disease Control, the WHO, and others went in to help control these outbreaks. And they came and went periodically. Things really changed dramatically, as Beth Ann mentioned, with the West African outbreak in 2014 in many ways. First of all, instead of a few hundred people involved, tens of thousands of people were involved. There were about 11,000 fatal cases. 3 countries involved, so extensive geographic spread. And the virus has moved into major urban areas of West Africa, and that increased their ability to spread very efficiently human to human. You heard about some of the practices, the local practices for taking care of sick people and taking care of dead people that contributed to that spread. And the other thing that changed between these 2 time periods was the emphasis on biodefense research in the US. So following the 2001 anthrax attacks, the US government put a lot of funding into developing countermeasures against both naturally emerging viruses like Ebola or biological weapons, viruses and bacteria, and also toxins that can be used as biological weapons. And by the way, Ebola does have some potential to be used as a weapon, although that's never occurred. And that resulted in a lot of increased capacity, including the development of laboratories around the US funded by the NIH, including the two national biocontainment labs in Galveston and Boston. And so we had the opportunity starting in the early 2000s to recruit scientists like Dr. Geisbert, um, who could really develop a new niche for studying these kind of emerging infections. And in previous times, when we only could work with these viruses at the CDC or USAMRIID, those agencies have their own priorities. They tended to react to new outbreaks to help control them, to do a little bit of basic research, to develop countermeasures that were mainly focused on protecting US military personnel. And the establishment of these new academic labs allowed us to do much more basic science and to allow scientists like Dr. Geisbert and many others at UTMB to span the scientific space the whole way from basic science to developing effective countermeasures. And so the reason that we had a vaccine in place to control that West African outbreak was because of work done at UTMB and other academic facilities, as well as at government facilities, to develop new vaccines, to test them in animal models, and to push them for licensure. And so we were extremely fortunate that at least at the end of the West African outbreak, that new vaccine was very useful in putting the outbreak to rest. And we were able at the very tail end of the outbreak to do clinical trials to show that the vaccine was effective. Before that, it had only been tested for safety. So that was really a game changer. Now, what's changed even a lot since 2014, you also heard from Beth Ann that we have situations now with unique circumstances of conflict converging with new outbreaks. We've discovered additional strains of Ebola viruses and related viruses that in the past we didn't consider major threats for large outbreaks like Bundibugyo. Now we see that it is a major threat because it's occurring in a conflict zone, a country with very limited public health resources. And all of these factors converge to make it very difficult to diagnose the outbreak initially. It was probably missed for several weeks before finally a diagnostic test was performed that would pick up the Bundibugyo strain. Many tests do not pick that strain up. And before the outbreak could be recognized, but by that point it had spread quite a bit. There were many cases, and it became difficult to trace the contacts of those cases, which was really the frontline public health response in the past. And so this outbreak really became almost out of control before it could be really resources could be brought to bear to control it. And of course, we also know that with diminished US presence in many parts of Africa due to USAID cuts, in scale back of programs like PEPFAR, the US has not been on the front lines of the response to this outbreak like it was in the past. We're now relying more on the WHO and European countries to pick up a lot of those efforts. So things have changed dramatically. There are some reasons for optimism, I think, related to our risk in the US, but many reasons for pessimism that Beth Ann very nicely outlined for you related to this almost perfect storm of an emerging viral threat in the middle of a conflict zone and a very poor, under-resourced part of Africa. But the Galveston National Lab, I think, has in the past made important contributions that put us in a little bit better position in some respects, and I think will help us to continue to make progress in addressing Ebola viruses and other emerging viral threats that we've seen come our way one after the other. So I'll stop there and then come back with questions later.
Thank you. And the questions are coming in. And we definitely want to get to them. So Dr. Geisberg, do you have any opening remarks?
No, I think Scott did a fantastic job of really giving a summary of the state of the field right now and our role at the Galveston National Lab. Yeah, I go back to the late 1980s when I worked at USAMRIID, and of course, we were working on Ebola then because the former Soviet Union was looking at weaponizing it. So there was that, the kind of biodefense interest there. And I came here in 2010 and really had a great opportunity to join an academic program and where we've spent a lot of time trying to develop medical countermeasures, vaccines, and treatments. And I think it's been nice to see some of those used. The Ervebo vaccine that was used in the 2015, it was used in 2015. It was produced by Merck. Fortunately, as most of you know, there's a small global market for these kinds of products. I mean, people really aren't interested, or companies, big pharma, it's not a moneymaker. They're not interested in really making a vaccine or a treatment for Ebola, like you're going to make a drug that's going to cure cancer or tackle heart disease or something like that. So we got the opportunity to participate in that. One of my colleagues, Heinz Feldman, and I developed that, the initial technology used for the Ervebo vaccine. And the current Ebola Bundibujo outbreak right now, in DRC, we have a vaccine that was based off of the Ervebo technology specific for Bundibujo. And I think, as most of you know, there's six different species of Ebola viruses, and 4 of those cause disease in humans, and 3 cause lethal disease in humans. And a lot of the emphasis was put on Zaire, well, because of the Zaire species, because of that large outbreak in West Africa in 2014-15. But we did develop a vaccine specific for Bundibujo. IAVI has currently picked that product up and is working. CEPI is starting to fund that. Unfortunately, we've had some organizations like CEPI step up and provide some resources to help with this. And so it looks like that vaccine will move forward. And as Beth Ann said, I think contact tracing, you can have great vaccines and great antivirals, but really getting in and treating people quickly is really important to containing these outbreaks. I think that's a really huge point. I know we've got a lot of questions probably coming in, so I'm going to stop there and hopefully we can take some questions from the participants.
Thank you so much. This really does set the stage for answering these questions. So I'm going to go ahead and jump into the questions. I'm going to go a little out of order because we were getting several about the impact to the United States and the residents here. So I'm going to jump into this one specific question because it does seem to represent the questions we got during the registrations. With millions of fans attending the FIFA World Cup matches, including today's Portugal versus the DRC game, which is in Houston, how significant is the risk of contracting a virus or other infectious disease at such a large-scale sporting event? And what precautions should spectators take to protect themselves? Maybe I'm going to go to Beth Ann first to answer that question, and then the rest of y'all can chime in. Beth Ann?
Sure. So I'll mention a few things, and then I would love to hear from definitely from the other 2 panelists. When we think about Ebola virus, okay, the chances of an Ebola outbreak happening because of here in the U.S. is very, very low, is very, very minimal. Okay, you have to think about the mode of transmission. Ebola is not transmitted by air or droplet. It is transmitted through bodily fluid and direct contact with those bodily fluids, and you have to be symptomatic to transmit the virus. And so it's the likelihood of something happening in the U.S. is even despite having a big event, et cetera, is very, very low. And so I do think that the risk there is even though Ebola is a very scary disease, it is still contained in those geographical areas, and we talked about the challenges of stopping it in those geographical areas because of some of the dynamics. Those are the very dynamics that are actually probably slowing it down from spreading to coming here in the United States. So I think in terms of that case, and I think we also have to be careful about, even though a team is coming from a country where this outbreak is happening, you have to look at where the cases are contained, where they're located. Did team members, making the assumption that someone is coming from the DRC, it automatically means they're at a higher risk for Ebola. We do have to be careful about not stigmatizing folks for that reason. They're not coming from that region, so they've likely not had any exposure, which means they're not bringing cases into the country. So I'm going to leave it at that, nice and simple. But I'd love to hear from some of the others to talk about other potential threats for other infectious diseases, which could be a result of a large-scale event like the World Cup.
Sure.
I
Dr.
think
Weaver.
in general, when we have a convergence of people from all over the world for an event like the World Cup, there are certainly lots of infectious diseases being carried by those people coming our way. Fortunately, this is happening in the summer when a lot of the respiratory viruses don't transmit as efficiently. But there are things that people can always do to protect themselves from heightened risk during an event like this. Just washing our hands frequently. Um, Same kind of thing we should be doing on a cruise ship where, big outbreaks of human-to-human viral transmission occur. If you're in a big crowded stadium, washing your hands, keeping your hands away from your mouth and other mucous membranes if they are contaminated on a handrail or something like that is always a good idea, no matter where we are for this kind of risk. But I also want to point out that I think we are in a little bit better place for other reasons. Even if a person did import this Bunabujo strain from the DRC, our hospitals in 2014, really our main failing was that we assumed that any hospital in the US could contain a case and prevent local spread in the hospital or into the community. And that was not quite true. In Dallas, we had a West African man who infected 2 healthcare workers. They had to be evacuated to other hospitals that are specialized for this kind of care. And fortunately, they survived, but the original man who traveled passed away. Thanks to that experience, but also probably more importantly to COVID, our hospitals and healthcare providers are much better trained to use personal protective equipment, to know how to don and doff it, which is really the key skill for preventing Ebola spread in a healthcare setting, is to know how to take off that PPE without contaminating your skin and then infecting yourself or others. And so I suspect we're much better off due to better training during COVID, better supplies of PPE in our hospitals. And also now we have 10 regional medical centers that have specialized facilities and training to handle these kinds of cases. So now, if we had a patient diagnosed in Dallas, they would be transported to UTMB, where we have one of these specialized care facilities. It's basically a high containment environment with a 5-bed hospital unit. We have a physician who runs that unit who has experience in several Ebola outbreaks taking care of patients. And we have a healthcare team that is trained periodically with all the PPE, donning and doffing, and all the other procedures. We're in a very good position to take care of a patient like that much more safely than we were in 2014. So I agree completely, Beth Ann. This is a very minor concern at this point that we would have any kind of an outbreak here in the US. But we can never say that risk is zero, and we need to remain vigilant. I know the U.S. government is being very careful about screening incoming travelers from that part of the world, and I feel pretty confident that we're okay, even with the World Cup here right now.
Thank you for that. Dr. Geisbert, if you don't want to add to that, I have a question for you.
Sure, yeah, go ahead.
With the recent advances in Ebola diagnostics, which laboratory technologies are currently recommended as most important?
Yeah, I mean, PCR assays, probably go back decades, and really that's pretty much what is the standard where you're detecting the genomic material. There's been a lot of development I'd say since the 2014-15 epidemic in West Africa to have what they call these rapid tests, where you're looking at, assays where you're not really looking for the genetic material, you're looking for the protein or the antigen, the viral antigen, and where you can get an answer, pretty quickly, 15 minutes to 30 minutes, kind of thing. I think one of the challenges that was faced, and I think Beth Ann talked about this a little bit, is that there was a lag during this current Bundibugyo outbreak, where sometimes the PCR can be a little too specific, and you're detecting one species because there was so much focus placed on the Zaire species of Ebola, because that's what caused the big epidemic in 14 and 15, and it caused the second biggest outbreak in probably 18 to 20 in the same area. So everybody's thinking Zaire, and maybe next to that is another species called Sudan, and it kind of forgot about Bundibugyo. So it took a while before the specific reagents were available and before that diagnosis was made. And meanwhile, the outbreak is going on. But I still think, probably some development in having assays that are better at detecting across multiple species of Ebola, and maybe thinking in that direction. But certainly PCR is still the gold standard for this type of thing.
Great, thank you very much. Would anybody like to add to that with laboratory diagnostics? Okay, so Dr. Geisper, we'll stay with you. And this is about unknown samples and how you handle those. How do you handle samples from an Ebola outbreak area that aren't confirmed positive, but they are from an outbreak region?
Yeah, I think basically we're always thinking if there's a chance that it can be Ebola, we treat it like it's Ebola until proven otherwise. So, I mean, I think that's, we're fortunate here that we have a BSL-4 lab where, we have a safe environment to do those types of studies, and in a very safe way. So I think, safety comes first here. So I would, say that definitely, we would handle something that could potentially have Ebola like it was Ebola.
I'd like to mention one other aspect related to this question. So we can import and work safely with these kind of samples, but getting them imported can be extremely difficult. And this is a case where I don't think we've made any progress since 2014 or before. Getting any kind of sample from any patient imported from another country around the world has become more and more difficult. More and more permits are required. In this case, you'd probably need a CDC permit. Shipping the sample has gone from costing hundreds of dollars to costing many thousands of dollars. And many countries are simply not willing to share samples like this. They consider it potentially intellectual property if a virus strain was recovered and used to make a new vaccine, for example. And there have been international conventions put into place that make it even tougher to protect exploitation of the endemic countries by Western scientists who want to develop a new product. So it's very, very tough. And one of our functions at UTMB, as the World Reference Center, is to collect strains from all these kinds of outbreaks to add to our collection. So when a new vaccine is made, we can test it against lots of different Ebola strains. But that's become tougher and tougher. And it's a real problem. I was hoping that it would improve during COVID, but it really didn't. And so this is a challenge that the international scientific community needs to continue working to find ways to improve the sharing of samples so we can respond faster and more accurately to this kind of outbreak by getting the samples into the hands of the scientists that can run the state-of-the-art tests on them.
Thank you for that. Let's see. Dr. Weaver, we'll stay with you. Given the current Ebola outbreak, what are the most important preparedness measures that low-resource countries can take? And I'm going to expand that question a little bit to say, what about low-resource hospital systems, perhaps rural hospital systems along the border? What prevention measures can they take?
Well, I think probably the most important overall would be training of their staff and implementation of the right PPE. So that if a questionable case comes along, someone with a hemorrhagic fever, could be Ebola, could be Lassa fever in Africa, or a number of other deadly diseases, they can at least prevent spread within their own healthcare facility. So that means having the right kind of gloves and masks, even some very basic things like sharing syringes and needles that have contributed to spread in the past. Those have to be completely eliminated. And we have to make healthcare settings safe, and the healthcare providers themselves have to be safe, because otherwise, what we're seeing now in the DRC happens. The healthcare providers themselves are infected, they're sick, they die. There's nobody left to take care of anybody. So we need to improve the training, the facilities, the resources, and the way of PPE available. And then we have to improve diagnostics. If we have to wait weeks for a sample to be sent internationally to a state-of-the-art research laboratory where they happen to have the best test for Bundibugyo, we've lost the chance to control that outbreak, to initiate the contact tracing and things like that. So we need to have simple tests like Dr. Geisbert mentioned, these point of care tests that can be done in minutes at the bedside for a few dollars, instead of spending thousands to ship a sample and run a state-of-the-art test in a WHO lab or an academic or a public health lab. So we can respond much more quickly to these kinds of outbreaks. And that's true in many places around the world, but especially in a place that's got major conflicts going on that further disrupt the whole healthcare system, like we're seeing in the DRC.
Related to your answer, a question popped up, and I'm not sure what kind of facility this person is at. The question is, where would you send the sample? Could you run the sample in-house in the hospital, or will it contaminate the laboratory? That question scares me a little.
Well, if the healthcare facility has some pretty simple containment systems, like a biological safety cabinet, they can handle a sample like that. Even if it does contain Ebola virus, they can quickly inactivate it. And at that point, it's safe for anyone to handle to set up the test, whether it be a PCR test or a bedside rapid diagnostic test. So the key would be to have an initial inactivation step available in maybe not every little healthcare facility in all of the DRC, but in at least a few regional centers where they could afford to set up that kind of containment. And just to give you an example, a biological safety cabinet is what protects Dr. Geisbert in the BSL-4 lab against Ebola virus. He also wears a spacesuit, but that's only if something goes wrong in that cabinet or he makes a mistake with the procedure he's following. So there are ways to control these risks at fairly low cost to allow the testing to be done locally. If it has to be sent to a central national laboratory, even in the DRC, we're talking about many hundreds of miles, great delay and cost. It's just not going to allow us to get a quick diagnosis of these outbreaks and to get on top of controlling the spread.
Dr. Geisberg, would you like to add to that answer?
Yeah, and I agree completely with Scott. And I think to clarify a point, the question that came up before about us looking at samples that would be sent here, that's mainly if we're going to, we could do an assay here where we could diagnose something, but a lot of times we're amplifying, we're growing the virus in the lab so we can study it, so that we can see if it works against the countermeasures that we developed. And Scott's right about, this can be done safely in country if you have the right equipment. And a lot of times if you're doing an assay, you're inactivating the sample to run the assay. So I think it definitely can be done safely in country. So it's kind of just to clarify a little bit of what we may do here and versus what you're doing if you're doing a PCR assay, for example, in country.
Thank you. Related to that, and we'll stay with you, Dr. Geisberg. Um, a questioner asks if a long-term goal of an institution is to establish a diagnostic laboratory for Ebola. Are there available resources to assist with procedures such as a competency checklist or facility requirements? And that might be NETEC, but what resources are there out there to help somebody who wants to run diagnostics?
Yeah, and I think this is Scott had kind of touched on this earlier in his opening remark about, this historically was done by um, the US CDC and some other organizations who would go into these areas and really train people and get diagnostics up and going and so that a lot of this could be done on site. So now, it's kind of different. I mean, WHO has tried to step in and some of the other facilities. Scott, do you want to follow up on that?
No, I think I agree, Tom. In the past, for example, the West Africa 2014 outbreak, the CDC went in, the U.S. military went in, UTMB scientists went in to supplement those efforts. One of our senior scientists, Tom Kizak, who had been involved when he was with the CDC in controlling these outbreaks, was recruited back for a few months to help out, and he went in and ran the epidemiology program for the CDC for a while. One of our physicians was brought into West Africa to help take care of patients. So we have the ability to set up these kind of facilities. And actually, there's one NIH-sponsored program we've been heavily involved with at UTMB called the CREED program, Centers for Research on Emerging Infectious Diseases. There were 10 of these centers funded for the past 5 years. One of them, 2 of them were headquartered at UTMB, and one was in West Africa. And our center put a lot of emphasis into capacity building and training. We still have a Fogarty training grant for scientists from West Africa. So one of the main goals of this network was to improve capacity for diagnostics and surveillance. Now, that program was terminated a year ago. I'm hoping that it will come back, and we've recently heard some rumors that it may be coming back. But that's the kind of program that I think is very important, not only to helping us understand how these kinds of viruses emerge, where and when are people exposed, what are the risks, but to keeping that capacity up and running in these parts of the world so that we don't rely on this helicopter CDC mission every time there's an outbreak to get even the minimum capacity put into place, that we have more sustainable capacity in these countries.
Thank you for that. We have time really for one more question. I'll ask that the 3 panelists keep it brief. Dr. Weaver, we'll start with you, and then I'll go to Dr. Geisberg and then Beth Ann Moscow. In your view, what is the single most important research question about Ebola that remains unanswered today? Dr. Weaver.
Well, this is really maybe a little bit more geared to Dr. Geisberg. He's the expert on Ebola viruses. I'm more ecologically and epidemiologically oriented, and I think we really need to understand where the index cases are infected. So we have a pretty good idea that Ebola viruses come from bats. They circulate naturally in bats in the environment. And a lot of these outbreaks are associated with mines where bats tend to roost in very large numbers. They can shed incredible amounts of virus that gets stirred up and can infect mine workers. But we really don't have a smoking gun for where most of these outbreaks occurred. And if we had a better understanding of which bats, which caves, what times of the year, which kinds of workers in those mines are at risk, we could protect them a lot better, and I think prevent a lot of these outbreaks from the very start. So that's my personal preference for the kind of work I'd like to see get done.
Thank you, sir. Dr. Geisberg?
Yeah, Scott took my answer, but that's okay. So I'll go to number 2. I think, being a virologist and being interested in pathogenesis, I think, trying to understand exactly the mechanisms by which Ebola causes the disease it does. And we know we've learned a lot in the last several decades about that. But I still think, you've got all these different types of species and strains of Ebola. And then you have just, a virus that kills up to 90%, like the Zaire species. That's not a very effective virus. I mean, it's not great for a virus to kill its host. So just understanding, how the virus causes disease and why some people are resistant, right? We know that some people, there's cases where people we know are exposed to Ebola and they don't get sick. And, we see different mortality rates with different species and strains of Ebola. And a new one that recently came out, Bombali, that doesn't appear to cause disease. So that would be a question. I think we need a lot more research into that.
Thank you. Beth Ann?
Well, all of the top research topics have been taken already. So in addition to those critical areas that have already been mentioned, I do think we also need to get a better handle on what we're doing as we're getting these questions answered. There's still going to be outbreaks. There's still going to be things that need to happen, on the ground. And so, what are the ways that we can improve our preparedness? How can we get communities better involved? What's the kind of engagement that's taking place? What are the ways in which, we sort of live our life in a normal state, and then an emergency happens and everything sort of goes spiral and we forget about any kind of thing that we've done in the past. So how can we do a better job in resource poor countries and communities around preparedness, around response, and community engagement, so that when we have a better handle of where the virus is and where it's going, communities themselves feel more empowered and better engaged to be able to be part of that response, and part of the planning as well. So I'd like to help us to understand that better.
Thank you. Thank you to all of our panelists. Dr. Honey, this has been fabulous. I think that there's been a need for more information out there since the Department of State Health Services webcast last week. I'm so happy that we were able to continue this conversation. So there were so many questions that came in, and I'm very grateful to the entire audience for sending those questions. We are going to make our best effort to compile those questions, add the answers, and post those on the P2R website, which is currently under construction. So we are going to do our best, and at the very least, we will try to email those out to everybody who registered. Another reminder, please take a photo, go to this QR code, take our survey. It's very short. It'll really help us out as we move forward with other webcasts, especially as we respond to conditions on the ground around the world. So please join us in July. I don't have an exact date yet. We will be discussing the New World Screwworm. We will be adding to the conversation started by the Texas Epidemic Public Health Institute about 8 months ago. So please be aware of that. And I thank you everybody for joining and for all the hard work in putting this together, including our staff and our graduate research assistant. Have a lovely day and be on the lookout for our recording in about 10 days. Thank you again. Bye-bye.
Thank you.
Well,